So anyway, that's that. And so this week in lab, you guys will be working on PhysioX. I'm actually going to have you do PhysioX 5 and 6 because there are two cardiac labs, and I want both of them to be done before the test next Thursday. So we'll finish out lecture material this week. Next Tuesday we'll play Jeopardy, and then next Thursday will obviously be the test. This Thursday there is a PowerPoint file for the blood pressure regulation, but I never use it in lecture. But what I did was I basically made an old-fashioned lecture where I'll just use my markers and we'll dirty up the board, kind of like we did with the circulatory path. But everything from that came off of the handout. So the handout, it will actually be useful for you for study purposes. And I think that's about it. So welcome back. And but now we have to get back to work.
Did you tan?
No, I just shaved.
Oh.
Yeah, just shaved.
There's something going on.
No, I should tan because I'm like pretty. I'm not like pasty
You look
white,
darker.
but well, I did wine tasting over break.
Oh.
Without,
Give you a little color.
a lot of sun.
Well, that vitamin D.
But I spent the next 5 days after that in the gym, so I
Yeah.
enjoyed myself, but then I had to make up for it. Okay, so cardiac output. Think, all the way back to 2 weeks ago, or maybe a week and a half ago. What was the mathematical equation that we used for to illustrate cardiac output? CO equals SV times HR. Okay, so what is SV?
Stroke volume.
Stroke volume, and define that for me, please.
End of diastolic. Minus.
Not in equation form, but just generalize. What is stroke volume?
How much?
The volume per ventricular contraction. Okay, so when the ventricles contract and send out their blood, that's stroke volume. How much blood they actually pumped out. And obviously, HR is heart rate. Okay, so what we're dealing with here is a real important concept that you guys will definitely have to be familiar with as you go on to bigger and better things, because a lot of what you guys are going to experience in terms of treating patients is probably going to revolve around this in some way or another, because we're dealing with two very common things: blood pressure and heart rate. Okay, so cardiac output's a really big deal. So literally, it's the volume of blood pumped out by each ventricle per minute. So we're dealing with two things: volume and time. All right. So essentially, what we're going to do today is we're going to break that equation down into two parts and talk about the factors that affect stroke volume first, and then we'll talk about the factors that affect heart rate. Because you don't have to necessarily be a math major, I'm not, but I do know that if I look at an equation like this, and if I manipulate either of the two variables on the right, that's going to affect what's on the left. Okay? Whether I increase or decrease either one or both of stroke volume and HR, that's going to have some impact on cardiac output. So that's what we're going to do. We're going to talk about that. And then I'm going to give you guys a real little short assignment, sort of more of a discussion prep kind of a thing to do before Thursday. That one, we'll start Thursday off with a little discussion after your super fun double quiz. Okay, so average cardiac output for an individual is roughly 5 liters a minute at rest. Okay, maybe a little bit more than that. I think your book might say 5 1/4 to 5 3/4, somewhere right in there. We're not gonna split hairs over a little bit of a difference there. Now that's average. Okay, now cardiac reserve is a term you want to be familiar with, and that is the difference between resting CO and maximal CO. Is there such a thing, do you think, as maximal CO?
You mean like a limit?
Well, let's say Killian weighs 500 pounds. Okay,
Pretty
big
close.
guy. And gets accepted to be on The Biggest Loser. So he shows up and finds out that Jillian's going to be his trainer. He's obviously scared.
Killian,
Okay,
huh?
rightfully so, he should be. At rest, his CO is 5 liters per minute. But now, Jillian takes him into the gym, okay, and crushes him, literally, okay. How do you think his cardiac output's going to be at the end of one of her workouts versus how it was at rest? It's going to be friggin' high. Why, though?
Because your heart's pumping at a faster rate.
Because your heart's pumping at a faster rate. So you take that example of somebody, let's say, after an extreme workout, that would be their maximal CO. Because not only is their heart beating at a much faster rate, but it's also beating stronger and harder. Okay? So you get those two things, and that's going to up cardiac output. So let's say it goes up to 20 liters a minute, just as an arbitrary number. Cardiac reserve would be what?
15.
15. The difference between maximal and rest. Okay? So, is cardiac reserve constant?
No.
No.
It changes.
Because it changes. Okay? What might be maximum for one person might be different for another. Okay? So don't get stuck on the idea that cardiac reserve is 15. Okay? Understand that cardiac reserve is the difference between maximal and rest. Okay? Because like we said, it can change. Because we could take this entire first row. Okay? And bless you.
God bless you.
And make them do 50 push-ups each, okay? And measure cardiac output again. It's going to be different, okay? Different all across the board. So, again, the point of saying that is to set up what we're doing now. So what we're going to do is again, talk about stroke volume and heart rate and how there are things out there that affect each one of those. So that way, you start to get it in your head that these things affect cardiac output, all right? And then what was I had it up here on the board, I think the very first day, what was the relationship between cardiac output and blood pressure? Was it direct or inverse?
I don't even remember seeing that.
Direct. And a direct relationship means what?
That if something happens to one, it's going to happen.
What happens to one happens to the other. Okay? So if cardiac output goes up, blood pressure goes up. Cardiac output goes down, blood pressure goes down. All right? So by the end of Thursday, my challenge to you guys is to really be thinking out of the box. So that way you can take, and I'll show you I'll put up well, it's not really an assignment, but I was going to give it to you guys here in class and we were going to discuss it. But I have this whole list of variables for you guys. And so my challenge for you is to take a look at any of these variables and say, okay, this is going to affect heart rate, okay, this way. And if I change this variable, it's going to change heart rate, that's going to change cardiac output, and that's going to change blood pressure. So you've got to start to think linear, okay? What happens to one is going to have an ultimate impact on something else, okay? So, well, we already know this, but let's just review it for funsies. So, stroke volume in equation form is what? EDV minus ESV. And you can see what those are again. So, EDV is the volume in the ventricles at the end of diastole. It's really deep, right, in diastolic volume. And then ESV is what is left over, essentially, at the end of systole. So the ventricles contract, eject their blood, and ESV is what's left over. Do the ventricles eject 100% of their content?
No.
No, they do not. Okay, so stroke volume again is that total amount that's pumped out per ventricular contraction. All right. So we are going to focus on stroke volume first. and the three factors that affect stroke volume are preload, contractility, and afterload. So preload, contractility, and afterload. Preload and contractility are similar in a manner of speaking because we're talking about two things that actually will increase or even decrease the strength of contraction. But preload, and I'll point out the big difference between the two. Okay, but if we change either one of these three, okay, up or down, that is going to have a corresponding change to stroke volume. And if we change stroke volume, what do we change? Cardiac output. We change cardiac output, we change blood pressure. Okay? So, again, start to think big. By changing contractility, I change a sequence of variables that will ultimately change
Heart rate.
blood pressure. Okay? I want you guys to really focus and obsess about blood pressure, because I mean you can disagree with me if you want, but let's face it, a lot of health issues in society today revolve somewhat around blood pressure, and as you guys go on, you know, your family and friends are going to know that you're going into healthcare, and they're going to expect you to know all the answers. I mean, I never was a nurse, but because I teach what I do, my family looks at me like that. I'm like, well, why don't you know? I'm like, I don't know. I don't have all the answers. Go look it up.
Google.
Yeah, Google it, for heaven's sake. You know, don't expect me to know everything. But your friends and family are gonna look at you guys like that. Okay? So, blood pressure, big deal. So, preload. And that page number might actually be wrong, so don't put too much stock in that. So, preload. What is preload? Okay, so preload is the tension placed on the myocardium. What's the myocardium?
The muscle, the heart.
The heart muscle. Okay, heart has what, 3 layers? Okay, the myocardium is the middle of the 3 and it's the thickest, so it's the heart muscle. So, preload is the tension placed on the myocardium, okay, by the blood that fills up the ventricles and stretches them. Think back many weeks ago whenever we talked about skeletal muscle, right? And we talked about the length-tension relationship. Remember we had that one graph up there that kind of went up and plateaued and then went back down, right? And the maximum force generated in muscle was in a range where we had the muscle at its maximum length, maximum resting length, and then a slight stretch. Okay, and that was the essence, I guess, if we would say, behind plyometric contractions and why they're so forceful. Okay, now take that principle and apply it to this. Okay, you're able to get a strong contraction out of your quads. Okay, if you stretch them slightly right before they contract. Okay, now again, take that, apply it to this. Blood is filling up the ventricles. Are the ventricles completely rigid? Are they hard chambers? No, they're flexible. They're elastic because of the myocardium. So what's happening to the myocardium as it fills up? It stretches. Okay? In the skeletal muscle example, what did we maximize when we stretched the muscle slightly, right before it contracted? So cross-bridge formation. Okay, it starts with a C. Okay, we maximize cross-bridge formation in skeletal muscle when we stretch it right before we contract. Does cardiac muscle, is it striated like skeletal muscle?
No. It's smooth muscle.
No.
Who votes for smooth? Who votes for striated? Oh, shame on you. It's striated. It's under involuntary control, but cardiac muscle is striated, which means it has actin and myosin, just like skeletal muscle. Okay, so when we stretch that myocardium by filling them up, by filling up the ventricles, we place the actin and myosin, we maximize cross-bridge formation in the myocardium, and we can therefore get what? A more forceful contraction. Exactly the same way we did when we stretched our quads or any other muscle, right before we contracted. That's preload. Refers to the tension that's placed on the myocardium right before it contracts, right before the ventricles contract, because of them filling up and stretching. Okay? Frank-Starling law of the heart. Okay, is basically a fancy way of explaining what preload is. Okay, not the Kurt-Sterling law of the heart. So if you've had micro, you should laugh at that. It's not a very funny joke, but yeah. Thank you for the sympathy laugh. Okay, so Frank-Starling law of the heart is basically explaining preload, which again is the tension on the myocardium because of the stretch and due to the presence of the blood. Which is, what do we call that? What is the blood that makes its way back to the heart? Venous return. Okay? So, let's put our thinking caps on, which, now that you're back from spring break, you've got to have it on again. Okay, you didn't have to have it on for a week. Okay? Venous return, so that's the blood that makes its way back to the ventricles. How do you think venous return is going to be affected if, let's say, we dramatically increase heart rate?
It's going to come back faster.
Is venous return going to be higher or lower?
Higher.
The amount of blood making its way back into the ventricles, filling up the ventricles. What do you think?
I think
The
higher.
amount of blood making its way into the ventricles if the heart beats too fast. Lower. Why? Because it's pumping it out too fast. Okay? But if the heart rate's pretty low, they can fill up a little bit more. Okay? Preload. So venous return, again, is that blood that makes its way back into the ventricles. So that's going to change with heart rate especially. And so if venous return is low, preload is also low because there's just not that stretch. Okay, that's why we mentioned that here. Okay, what about blood loss? Okay, let's say I don't know, you go wine tasting with Rogers, and if you're 21, of course, and you have a little bit too much. Okay, you find that 3 wineries was your limit, but I pushed you to go to 5. And at that 5th one, okay, you put down that glass of Zinfandel, and as you're putting it down, you trip and you fall, okay, and the glass breaks, and you cut your hand open, and it's just pouring out blood all over the tasting bar. Okay, making me mad and making everybody else mad because you're taking away the person that's pouring. Okay. If that blood is now all over the place, where is it not?
In your body.
It's not in your body, and it's not making its way back to your heart. Okay, so severe blood loss is going to do what to preload? It's going to make it go down. Okay, it's going to make it go down. So, are we all clear on what preload is? Okay, the tension placed on the myocardium before it contracts. Okay, so we increase preload. What kind of contraction do we get? We get a strong one. We decrease preload, we get a weaker one. Now, contractility is referring to the strength of contraction regardless of the stretch, okay, independent of stretch. So this one, preload, we can even simplify it more and say it's affecting the strength of contraction based on stretching the myocardium. Contractility is affecting the strength of contraction independently of the degree of stretch. And this has everything to do with cytoplasmic calcium levels. Okay, what is cytoplasm?
Fluid on the inside of the cell.
Fluid on the inside of the cell. So cytoplasmic calcium levels is referring to what? The amount of calcium inside the cell. Okay? Now, we have to go back to unit, well, I guess it would be unit 2. What role did calcium play in skeletal muscle contraction?
Make the vesicle fuse to the side of the cell.
In
muscle?
In muscle.
Okay.
Calcium
Onto the
attached
troponin.
itself to troponin and undid what? The blocking action of tropomyosin. So calcium increased the number of potential what? Cross bridges. Okay? Now, take that principle from Unit 2 and apply it now. Okay? If we increase cytoplasmic calcium levels, okay, in the cardiac muscle cells, what does it potentially expose? More binding sites. Okay? And if we do that, actin can bind to the myosin and give us more cross bridges, which is going to lead to stronger contraction. Okay? So when we increase contractility, it's more than likely going to be done, on average, by more calcium. So we increase calcium into the cytoplasm of the cardiac muscle cells, more cross bridges form, boom, more forceful contraction. That can be done neurologically, by sympathetic stimulation, okay, sympathetic impulses along the sympathetic cardiac nerves, and those nerve endings will actually liberate epinephrine and norepinephrine, and those will actually facilitate the calcium into the cell. Or you can do it artificially by injecting epinephrine into the body, which you might see with somebody with an EpiPen, during a severe allergic reaction. Blood pressure bottoms out. What is epinephrine going to do? It's going to increase heart rate for one, and it's going to facilitate more calcium into the cytoplasm, which gives us more forceful contractions, boosts blood pressure. Okay? Now, down here, positive and negative inotropic agents. Okay? Now, let me explain what that means, and then because this is going to be your discussion-based assignment for Thursday. Okay? In general, if we were to have these two lines here and say positive and negative, positive would probably mean that it's going to increase something, and negative will decrease it. All right? So what category are we talking about here? Contractility. So what do you think an inotropic agent is? Something that affects contractility. All right? So this is real deep. What do you think a positive inotropic agent is going to do? Increase contractility. Therefore, negative is going to decrease it. Okay? So we've got some positive and negative inotropic agents here. Glucagon. Does anybody know what glucagon is? Well, you're like super close. Glucagon is a hormone that increases blood sugar dramatically. Okay? Glucagon is kind of like the antagonist of insulin. Insulin lowers blood sugar, glucagon raises it. Okay? Thyroxine. Does anybody know what thyroxine is? If anybody has thyroid issues, you should know what thyroxine is.
Is it make your body produce more hormones?
Thyroxine is a hormone.
Oh.
Thyroxine, I always get them mixed up. T3 and T4 are your two big thyroid hormones. Thyroxine, I want to say, is T3, but I'd have to double check that. Those two hormones are your body's primary hormones that regulate metabolism. Makes sense. Thyroxine levels go up. It's going to boost metabolism, make the heart beat harder. Epinephrine, we already know. Digitalis, okay? Probably not the most common one that would just, roll off your lips in casual conversation, which is why I'm going to have you look it up. And high calcium levels. Is that one kind of a duh? Okay, duh, yeah, that makes sense. With high calcium levels, yeah. Okay. Have you ever heard of, well, if we know high calcium levels increase contractility and therefore increase blood pressure, why would, let's say, a physician, if you go in, Tommy goes into the doctor, says, doctor, or finds out his blood pressure is super high. Doctor does all the tests, comes back and says, Tommy, your blood pressure is high because you have hypercalcemia, which means what?
High calcium.
Higher than average blood calcium levels, and that's why your blood pressure is too high. So he prescribes calcium channel blockers. What do you think a calcium channel blocker is going to actually block? Calcium. Hey, there you go. Calcium.
Now we're
That makes sense. A drug is going to block the receptors that take calcium into the cell. So we block that and we limit the amount of calcium that gets into the cardiac muscle cells. And what happens to the contractility? Lowers it. Manages it. Okay. Blood pressure now is managed. So negative inotropic agents. Again, some of these probably not going to be on the tip of your tongue. Acidosis, rising extracellular potassium. And then we just mentioned this one, calcium channel blockers. Okay. So what I want you to do is I want you to look up just a little bit of information, maybe like let's say if you were to make Jeopardy questions, like little trivia questions. How does thyroxine affect contractility? How does glucagon affect it? Digitalis. If you can understand a little bit about what these things actually do, that's going to work to your advantage a little bit later on. Because when I used to work in the ER, every so often you would hear of a nurse or a doctor referring to check their what do they call it? I'm brain farting. Digoxin, I think, is the term that they use. It's another way of saying digitalis. So that's one of the tests that one of the lab tests that they would order. Why do you think they would want to check that? If a doctor is going to check a person's digitalis levels, do you think their blood pressure is going to be too high or too low? That would warrant that. Might be too high. Maybe a person is taking too much of a medication. So the doctor has to check that because, hey, their blood pressure is too high. Or not taking their medication. Do people not take their medication?
all the time.
Have I told you guys my diabetic story?
No.
Oh, good. Okay. I try and save some of my better stories for different periods of time. One day I'm in the ER working and busy day, so we had double coverage for my position. I was a tech, and my colleague says, "Hey, Joel, go check out the guy in bed 5, I think it was." I said, "Hey, go check out the guy in bed 5." I'm like, "Why?" Just go check. It's cool. So I go in there, and it turns out that this man comes in for a dressing change, a wound dressing change on his foot. So I go in there. His situation was he was a diabetic that didn't take his medication, okay, and developed gangrene in his foot. And they surgically so imagine you're looking at the bottom of my foot, okay. They surgically removed his 4th toe and the 4th metatarsal. So he had this big V-shaped gap in his foot. And so he came in to have a dressing change, okay. Okay, we get excited about stuff like that because you work at a small hospital. Most of the stuff we see is constipation, an occasional chest pain that's anxiety or something. And so I get on my phone, click, take a picture of it. I didn't violate any HIPAA rights because there was no patient identification in the picture. And our doctor on duty was this electronics nerd, and so he goes out to his car and brings back his big old huge digital camera and starts documenting it, taking pictures. And so I take it, and this is when my mom's dad was still alive, and he was a diabetic, and you guys might know this type of person, especially in this area. Old Portuguese dairy farmer, okay? You know, that would make fun of me and my brother and give us bust our chops because we weren't up at 4:30 milking cows. You know, that wasn't. He was those hard workers. And so I'd go up to him and I'd say, "Hey, Joe, okay, look at this. Okay, this is going to be you if you don't take your meds. Okay, you better start doing what my mom tells you to do. My mom was taking care of him. So you better do what mom tells you to do, or this is going to be you." And it kind of scared him. I was like, yeah. I scared him. You know. Point being, people don't take their medication. Okay, so if you don't take your medication, you're going to have this in your foot. Okay. Afterload. So preload, contractility, and afterload. So what's the difference between preload and contractility?
Brain fog.
Did you forget already? One is affecting contractility based on stretch. The other is independent of stretch. Okay? So afterload. What is afterload? Okay, afterload is one of those things that is probably actually caused by blood pressure rather than something that changes and affects blood pressure. Afterload, think of afterload as the back pressure, okay, the back pressure against the semilunar valve walls. So the ventricles contract and send their blood out through the pulmonary trunk, out through the aorta, and then the valves shut, and there's a back pressure on them. Okay, that's afterload. Is that pressure that the ventricles now have to overcome to open up those semilunar valves and eject the blood. Okay, so let's say afterload is higher. Okay, now reason this out. If afterload is higher, which of your two blood pressure numbers is that probably going to be referring to? Because we haven't talked about this quite yet, but I want to challenge you to reason it out. Is it going to be your systolic or your diastolic?
Say low or?
It's your diastolic, right? So your systolic pressure is literally the pressure against the walls of the aorta as the blood has left the ventricles and is filling up the aorta. That pressure against the walls. But the blood, thankfully, doesn't stay there. It continues to move. And then the aorta recoils, okay? And that residual pressure that's left over is your diastolic pressure. And then literally, that would also be the pressure against the walls of the semilunar valves that the ventricles have to now overcome again to eject the blood. So if afterload is high, what is that going to potentially do to stroke volume? What do you think? What should it do? Think about it. Let's look at it like that. If afterload is high, if the pressure against the semilunar valve walls is high, what should that do? It should lower stroke volume, theoretically, because it should be harder for the valves to open up and eject their contents. Okay, so theoretically, if afterload is high, stroke volume should be lower. Theoretically, if afterload is low, stroke volume should go up. Now, in your average healthy person, afterload is relatively constant. Now, some of you may have, if you work in the medical setting, you may have seen this. I saw it a few times. People would come in with really high systolic pressures, but relatively normal diastolic pressures, and that never concerned the doctors as much as if it were a high diastolic number. I mean, I remember seeing a systolic number in the low 200s once, and the diastolic was probably in the 90s, and the doctors weren't like ultra concerned about it. But then if we saw diastolic numbers in the in the 100 to 110, 115, 120 range, that was an issue, because that means that the heart is going to have to start working a lot harder than it already is to get the blood out. So that was a problem. Okay, so how is it related to hypertension? Well, let's look at it as afterload is actually caused by hypertension. Okay, so this is one of those, we've been talking so far about things that ultimately will change blood pressure, but this is one of the, we have to kind of look at it from a different perspective, and with this particular variable. Blood pressure actually causes afterload. Okay, it's not going to, afterload is not going to change blood pressure. Are you with me on that one? Yes? No? Maybe?
Say it again.
Most of the things that we're going to talk about are, when we change them, are going to change blood pressure somehow. This is flip-flopped. Blood pressure changes afterload. This has nothing to do with anything, but if you guys have kids, especially like little girls, take them to see The Croods. It's like really cool.
Oh, I took my daughter.
I took my daughter to see it. Perfect movie for a dad to take the daughter to see.
We left after an hour. Why? She can't handle it.
Okay, sorry.
She's not old enough. Yeah.
All right. Okay. When's the time?
No, don't
We're
worry.
doing awesome.
Like as soon as
Okay. So, what are the three factors that affect stroke volume?
Preload.
Preload, contractility, afterload. All right, now, heart rate. Talk about a few things that affect heart rate. What is ANS? Autonomic nervous system. Okay, and so we have autonomic nervous system, and what are the two subdivisions of that? Sympathetic and parasympathetic. All right, and I think it was the previous lecture, we had that one slide that showed the sympathetic cardiac nerves and the parasympathetic nerve. What was the parasympathetic nerve? Vagus nerve. Okay. Do you remember, what were the three areas that the sympathetic nerves actually synapse with in the heart? Do you remember? SA node, AV node, Purkinje fibers, which consequently are the three areas that are capable of stimulating or regulating, we should say, heart rate. Okay? So it's convenient that those nerves synapse with those three areas. Now, vagus nerve only synapses with the SA node and the AV node. And I just crossed out this last point here. I never ever talked about that. I don't even know why I still have it in there. It's not going to be on the test. Bainbridge reflex. But everything else is going to be on the test. Yay!
Party.
You guys have no idea how happy you would make me if you all passed the next test. I would seriously.
So a pizza party, right? You were just.
I would be tempted to buy you all lunch
Right?
if that happened. My wife probably would say no, because she's my financial advisor.
balances the budget and the check.
Yeah, which, ladies, if you go wine tasting with your husband, okay, and he asks you, well, what do you want to get? And you say, oh, whatever. Don't say that. Okay, that's a bad thing to say. because then I can get whatever I want. Okay. Anyway, I'm sorry. All right. So, sympathetic, parasympathetic, we're talking about, I mean, we mentioned this quite a while back, but if we were to generalize those two things, and I were to tell you, if you eat, or if I were to say, what happens to heart function if you increase sympathetic stimulation? Okay, what's going to happen? Probably the two main things: heart rate, okay, and contractility, which we've been talking about today. Okay, so sympathetic stimulation is going to increase heart rate, number one. Okay, and we saw just a few minutes ago, what did sympathetic nerves actually release? Epinephrine, which facilitates calcium into the heart. So epinephrine is going to have a major impact on the heart in two big ways. One, it's going to increase heart rate directly. Okay, it's probably going to. I'm trying to remember. I think it makes the. I have to double check, but I want to say that it actually makes the SA node, the cells of the SA node depolarize at a faster rate, which is what would cause heart rate to go up. So, increases heart rate, increases contractility. So epinephrine's a big deal here. What happens if we decrease sympathetic stimulation?
Your heart rate goes down.
Heart rate goes down, contractility goes down. Okay. What if we decrease sympathetic and increase parasympathetic? What happens? Decrease sympathetic, increase parasympathetic. Heart rate down, contractility down, and ultimately blood pressure goes down. Okay? So make sure that you understand the relationship between general cardiac function and autonomic activity, meaning sympathetic and parasympathetic. Okay? Because I can throw any number of combinations at you, and if you understand them, you'll be fine.
General cardiac function and what else?
The relationship between general cardiac function and the autonomic nervous system. Basically meaning you guys have to know what changes in sympathetic and parasympathetic stimulation mean to heart function. Yes?
So heart rate and contractility can increase by increasing sympathetic system?
Correct.
And then when you lower sympathetic system, heart rate and contractility decrease as well?
Correct. Correct.
And increasing parasympathetic lowers heart rate and contractility?
Correct. Correct. And like we mentioned in the last lecture, what would happen if the vagus nerve were severed? Heart rate increase. Probably not, I mean, to dangerous levels, but it would go up. Hormones. Okay. Hormones can affect heart rate, like we already know. Epinephrine is one of those unique examples that is classified as a hormone and a neurotransmitter. Thyroxine we've already mentioned. What about glucagon? What happens to your heart? What happens to a lot of people's heart rate whenever they eat a lot of sweets?
Goes up.
Yeah, that sugar will boost metabolism.
Especially in kids.
Okay.
Weird how that works.
Yeah, and it's always, I hate it when, we come home after being from wherever and grandparents are babysitting the kids, and what do grandparents love to do?
Spoil.
Give them candy, and especially right before parents get home, and right before bedtime. Okay? I hate that. So hormones, ions, calcium, potassium, even sodium can do that. Hypocalcemia depresses the heart. What is hypocalcemia?
Low calcium.
Low
levels
calcium.
in the blood.
Which kind of makes sense. We've been talking about that. Hypercalcemia, okay, can irritate the heart. Okay, and I'm actually going to show you something on Thursday in Interactive Phys that'll explain that a little bit more.
Does hypercalcemia, does that like overwork the heart, overstimulate it?
Yes. Yes. And then kalemia. What is kalemia? Refers to
Calcium.
potassium. So hyperkalemia,
Oh.
too much. Hypo, too low. Hyperkalemia interferes with depolarization by lowering the resting potential. So it lowers the resting potential of those cardiac cells, basically making it difficult for them to be stimulated, which is one of the reasons, and if you, I started to see this change, well, I was going to say, yeah, back in the 90s, but no, it wasn't. Probably about maybe 12, 13 years ago or so, you started to see a big change inside of hospitals, especially with the in-house pharmacies in the hospitals, and how they labeled their medications. Because there were documented cases of the pharmacy actually giving, like ERs or wherever it was, giving them potassium, and it wasn't properly labeled, and nurses were inadvertently injecting patients with potassium when they should have been giving them something else. And if potassium lowers the resting potential of those cardiac cells, making it difficult for them to be stimulated, what's that going to do to the heart?
Killing them.
It's going to stop it. Okay? So people were dying. So that kind of started a revolution inside of hospitals about how they label medication and even how they identify patients. You know, you guys probably have experienced that since then. You know, you go in and they'll probably ask you who you are, and they might even scan your wristband to confirm it, and they might ask you yet again before they inject you with something. Okay? Because they have to, because people were dying. Now, you guys can correct me if I'm wrong. Some of you may know this, but I'm pretty sure that potassium is one of the things that is what they actually use for lethal injections. Yes?
It's
Yeah.
sodium, potassium. Some
In the
crazy shit like
in
that.
the prison systems. And then exercise. Exercise affects heart rate. We already know that. Increasing exercise is going to do what to heart rate? Up. Okay. So hormones, ions, exercise, are those the only three things that can change heart rate? No. Okay, what are some other things? Stress. Okay. Pain. So stress, pain, and which I'm sure you probably will all feel next Thursday. Okay, hopefully no pain, but stress, yes. I want you to feel a little bit. A little bit.
A little bit of stress or pain.
A little bit of stress, no pain. I want you guys to be hurt. Little fear, little anxiety keeps you sharp. What else?
Stimulants like coffee,
Caffeine,
caffeine,
cocaine, meth.
Uh,
What about alcohol?
Yeah.
What is alcohol going to do?
That lowers it.
It'll lower it. Okay, so caffeine, which I didn't have my coffee this morning.
I don't drink that shit.
Yeah, like, yeah. Antihistamine, actually, we'll mention that on Thursday. Antihistamines can actually increase your blood pressure. Antihistamines can actually increase blood pressure because histamine is a chemical, it's actually a vasodilator, or actually histamine increases the secretion of another chemical called nitric oxide. That's a vasodilator, so that would like in an allergic response, histamine will actually lower blood pressure. So an antihistamine raises blood pressure. So, but you might see a warning on an antihistamine bottle, you know, not to take too much, or if you have blood pressure issues, you might not, which those of you ladies that may have been, when you're pregnant, you were probably told not to take antihistamines, which sucks, especially if you're pregnant during, like, allergy season, you know. So yeah, we can make a big list, and we'll talk a little bit more especially about some things that specifically increase and decrease blood pressure on Thursday. But there are numerous things that can both increase and decrease heart rate. This is just my explode chart. It's not going to, I'm not going to like blank it out and put it on the test and make you label it. Although that would be kind of fun sometimes. Maybe not for, it wouldn't be fun for you guys.
Extra credit point.
You guys don't need extra credit. I think that's it. Any questions on this stuff?
Let's review it just real quick.
Mr. Brain.
Don't do that.
Don't be that
Don't
dude.
be that guy.
I've just got loud anyway.
Question?
My husband, his resting heart rate is 41, and he has high blood pressure. He says he has high blood pressure because his heart rate is so low, but it has to work harder to push out all the blood. Is that just BS, or is that true?
His resting heart rate is 41, and his blood pressure is high. And he says it is that because it has to pump harder.
Yeah, he says the heart has to.
Well, then it'd be back.
There might actually be some truth to that, because, well, let's look at cardiac output, the equation, okay? If heart rate is low, okay, and the body wants to maintain adequate cardiac output, what's going to happen to stroke volume? It's going to have to go up mathematically. If one number is low, the other number is going to have to go up to maintain cardiac output. Okay? So, which is why, if you ever notice, like in cases of blood loss, like let's say with severe lacerations or stabbings or gunshot wounds, when a person bleeds out, okay, what's that doing to stroke volume? It's decreasing it. Which, if the body is going to maintain adequate cardiac output, what's it going to do to compensate? It's going to pump faster, okay, increase heart rate. So if his heart rate's low and his blood pressure is high, maybe, but you don't see that very often. With a well-conditioned person, their blood pressure shouldn't be high. I would question the cause. Hopefully he's not saying it's you. No, we don't want that. We don't want that. That's what I tell everybody. My blood pressure is high because of, it got high when I got married. And then when kids, that just, it's even worse. Yeah.
So if you have increased pulse and increased blood pressure, what is happening?
Well, it could mean that you're exercising. Could mean that.
Say a patient comes in, they're getting checked and their pulse is in the hundreds, their BP's like 200 over 100.
Well, a lot of people just are anxious when they go into the doctor. Like my wife is like that. Every time she goes into the doctor, even if it's just for a checkup, her blood pressure and her heart rate are always higher than rest. So my first guess would be anxiety, but they might be on drugs.
They could be on the too.
That's how my mom is. She won't stop talking to her, and they're like, "Can you just
Yeah.
just relax?" And,
That's the most annoying thing.
Yeah.
You're trying to ask questions and they want to give you a full explanation.
She's like,
Well, I got out of the shower and then I put one foot forward. And no, I just want to know how much you weigh.
So, yes.
On Thursday, the two sections that we
Like that.
quiz on,
I don't
the,
care.
This one?
That's normal.
and the one last?
No, this one and then what?
Oh, okay.
Oh, kids are being age. Damn.
Okay, so one thing, and I'll let you go with this so that way you can have a little bit of a break before lab. Remember, you want to be thinking you have 1 week left to make your decision about which test you're going to take.
Yeah.
Okay. So next Tuesday, okay? Next Tuesday, I will, or I don't know, I might just do it this Thursday so that way I can prep over the weekend. Yeah, this Thursday. This Thursday. That way I can get ready over the weekend. So you have until this Thursday to decide which test you want to take, traditional or essay. And the traditional test will not have any essay questions on it. Okay? The essay test will not have any traditional questions on it. It will be all essay, all short answer, 10-point questions and 5-point questions, and you pick whichever sequence that you want that will ultimately lead to 100 points, assuming that you got them all perfect. Yes?
Will we be able to know what essay questions will be asked?
Nope.
Just know it all.
Know everything.
Know everything.
Nope. No way, because there's too many.
13?
I think the last one that I wrote was between the 10-pointers and 5-pointers. There's probably like 14 or 15 of them. And but then it's you just pick whichever ones you want. I mean, to make up the 100 points. The multiple choice test is 100 questions, even, 1 point each.
Which one will we use for multiple choice?
Either one, doesn't matter. So remember, like I said, the only change is the same study guide, but the only difference will be for the essay people, if there are any, which Smart Money says no. If you choose the essay option, at 9:15, I take your paper from you, and we walk over to the lab, and I'll give you 20 extra minutes there. Okay, because it takes longer to do that test. Okay, but that's the only difference. Same study guide, same everything, except you just get a little bit of extra time.
And with this also, even if we don't choose to do the essay questions, we will still have Jeopardy on Tuesday.
Jeopardy doesn't change.
And then we still, if we don't get 1 or 4 wrong, we still get the cheat sheet.
Mm-hmm.
God bless.
No, cheat sheet is a standing offer, every Jeopardy. That doesn't change. That doesn't change.
We're making a decision before, Jeff.
So, I will be taking your orders on Thursday. So think about it. That'll be